TAVR indication expansion trials, what are new? What are next?
All right, so it's great to see the same panelists. You're going to be expert in my topic by the end. So I'm going to talk about TAVR expansion in indication, severe AS, no symptom, moderate AS, and others. I only have 8 minutes. I'm just going to cover new evidence that emerged from 2024, 2025. You see the list here. Asymptomatic severe AS, a lot of action in 2024, 2025. Moderate AS and heart failure, and also TAVR for aortic regurgitation. I'm not going to touch base on this just because, by interest of time, but just know that there's a lot of action also in this topic. So first, I'm going to talk about severe AS, no symptoms. This is the early TAVR trial that you might be familiar now. A prospective randomized trial for severe aortic stenosis with no symptoms among patients aged 65 years old and above, STS-10 or less, LVEF 50% or more. Asymptomatic status was confirmed by a low-level treadmill stress test, which increased the robustness of our trial. And everyone had a CAT scan before randomization, so we were ready to go. Randomized 1-to-1 to TAVR, S3 or Ultra to clinical surveillance, with a primary endpoint for superiority of death, stroke, and unplanned cardiovascular hospitalization. Patient flow, 1578 patients were randomized. From them, 42 were consented, From them, 42.9 was excluded, with 20% of the patients that were deemed asymptomatic, but actually when we interviewed them or look at their chart, they had already had a class 1 indication for AVR. So 901 patients were randomized 1-to-1 to either TAVR or clinical surveillance. So in summary, the primary endpoint of death, stroke, unplanned CV hospitalization was achieved and showed superiority of early TAVR with 50% reduction compared to clinical surveillance in the primary endpoint, with a number needed to treat of 6 at 2 years. There is no difference in mortality. We may have a chance to discuss that on the podium. Stroke, a trend toward lower risk of stroke with early TAVR compared to surveillance, which was very interesting and unexpected findings we can also discuss. And obviously the win was driven mainly by unplanned cardiovascular hospitalization. When we look at what was the component of this unplanned cardiovascular hospitalization, and where we run different endpoint, the one of death, stroke, and severe hospitalization for heart failure show a 40% reduction also by early intervention compared to clinical surveillance. One of the key aspects of this was the natural history of patients randomized to waiting. So when you have severe AS with no symptoms, at a median time of 11 months, you're going to need AVR. 26% at 6 months needed AVR, 47% at 1 year, and 71% at 2 years. And those data are very important to discuss with the patient when you sit with the patient as a shared decision-making process, but also when you plan the procedure to show those numbers may help to take a decision. What were the main symptoms that were driving the unplanned hospitalization or the conversion to AVR? Mainly shortness of breath, 83%. Syncope, 7%. So 7% of the patient passed out while waiting. Class 3-4 heart failure, 30%. So severe symptoms. We classify patient at the time of conversion to AVR either as asymptomatic, if there is a class 2A, 2B indication, for example, or mild symptom when they have progressive symptom, class 2, or if they have severe symptom, acute decompensation, such as heart failure, 304, pulmonary edema, syncope, ventricular arrhythmia, or drop of EF, etc. And what we saw actually is through the trial, among the patients that were randomized to waiting, 40% actually present with what I call acute valve syndrome. They crash and burn with pulmonary edema, syncope. 60% had what I call progressive valve syndrome or class 2, and only 9 patients, 1 or 2%, had no symptom but diverse indication, class 2A, 2B, orthopedic surgery, cancer, they need a surgery, etc. One of the key aspects of this acute valve syndrome is 40% of the patient needed AVR because of severe symptom, and the proportion of patients who present with severe symptom was consistent and constant through time, including the 6 to 12 month or the 0 to 6 month. So very unpredictable progression and very hard to predict as well. If you look at the different way to put this endpoint or primary endpoint, if you take death stroke or acute valve syndrome, conversion to AVR with severe symptom, we still have 50% reduction of the primary endpoint in favor of early TAVR, with, I would say, much more pleasant curve to the eyes, with nice separation through time. One of the reasons we didn't see a difference in mortality is on this slide. So the promptness and readiness of treatment in early TAVR was amazing. We were too good compared to reality or real world. So if you were randomized to early TAVR, you had your TAVR, your procedure in 14 days. So that's very quick. If you were randomized to waiting and you developed symptoms, you had your AVR in 32 days in average. So 90% of the patients were treated when they have symptom within 3 months, which is just unbelievable. And that's why we didn't see mortality, because the exposure to severe AS with symptom was very short, was 32 days. If you have 6 months or 8 months with symptom, this is why you die on the waiting list. And we didn't have that in early TAVR. And this is exemplified by those 30-day endpoint. When you look at patients that were randomized to TAVR, 30-day mortality, cardiovascular mortality, 0%. Patient that convert with AVR, 0%. So it's hard to show a difference in mortality when the TAVR is so good and everybody survive around the procedure. But when you look at the risk of stroke, 0.9% in early TAVR, 1.8% in delay AVR. New pacemaker, 5.7%, 8.4% if you wait. So there's still a little bit of gain by early intervention in terms of procedural outcome. You change a simple case and wait 1 or 2 years and you become more complex. We did a meta-analysis of the 4 trials that we have right now: Recovery, Avatar, Evolve, and Early TAVR. We just published this year to follow Early TAVR. And what we show, among 1,400 patients, 4 randomized trials, we show a trend in decreased mortality. We show significant decrease in heart failure hospitalization with early AVR. And we show a decrease in stroke, 40%, which reached significance in this meta-analysis. So I think for me, we've been sleeping on the fact that AS might be one of the strongest predictor of stroke, and then maybe I've sleep on this. But I said post-early TAVR to my patient first, with the referral doctor, refer early. I want to see those patients to plan their procedure, get organized, get a CT scan before they crash and burn, that a dental work plan, and plan the date of AVR. If you have symptoms, you need to be able to treat within 3 months or you're going to mitigate mortality. And there's no penalty to early intervention. So if a patient wants to go earlier, there's no penalty. As a matter of fact, there's trend to improve outcome, including stroke. Nicolas Van Megen present TAVR for moderate AS with heart failure. Unfortunately, the study was very underpowered with 89 patients in both groups, and was underpowered, didn't reach its primary endpoint. That being said, which is death, stroke, and heart failure hospitalization, that being said, is improve the quality of life. I think much more to come in the field of moderate AS, especially with the PROGRESS trial, which is enrolled, and we're going to have the result next year, and probably at TCT 2026. And enroll patients with normal EF or low EF, with at least moderate AS, with heart failure symptoms or sign of cardiac damage. So this is an example of patient we enrolled in a moderate AS trial, 82 years old, AFib, hypertension, came in heart failure in the hospital with a BNP of 5,000. This is the echo. You see severely calcified valve, not opening, but 1.1 valve area, 29 mean gradient, and everything is normal, flow normal. Typical patient that we put in PROGRESS, and there's no place in the guideline for this patient to be treated. We're going to see if the PROGRESS trial will be positive. So in conclusion, I believe early detection and potentially treatment of AS are key to improve patient outcome. Optimal timing of intervention beyond symptom is still to be defined for AS, and preemptive TAVR treatment it will be investigated in PROGRESS and EXPAND-2 trial. I think right now when I look at the guideline from 1998 to 2020, they are exactly the same. If you read the guideline in 1998, you're still up to date. It's almost the same guideline. So this is my personal opinion. I draft this on the plane. This is what I believe the guideline should be. Don't put that on Twitter, I may be in trouble. But I strongly believe that if you have severe AS with symptoms, you should be treated within 3 months. And this is from early TAVR. We mitigate mortality. I strongly believe if you have severe AS, you should be referred to a valve center to at least get a CAT scan and be seen by the heart team as soon as you have severe AS, with or without symptoms. I believe actually if you have severe AS with no symptom, It could be a class 2A. I put it a class 1 because actually there's actually no benefit of waiting. If you put intervention for severe no symptom as a class 2A, it means that waiting is a class 1 by default, which could not be because there's absolutely no benefit in all the trial we have. If you want to have 2 class 2A for waiting and treatment, it's fine. But I think for me, waiting, if you're not able, with severe no symptom, if you're not able to provide appropriate follow-up with no CT scan, should be a class 3. If you have severe S with no symptoms, and you wait, you do no testing, no CT scan, and you're in a geography where the next available appointment is 1 year, it's a class 3 for me. So I will stop there. Thank you so much.
Great. Thank you. So our next talk, we'll do the panel discussion after the 3 talks. So next is going to be Ajay Katani to talk about orbital atherectomy versus conventional balloon angioplasty for severely calcified lesion, the ECLIPSE trial. Ajay.
All right, thanks so much. Moving to somewhat smaller calcified arteries and vessels, I'll be talking about orbital atherectomy versus balloon angioplasty for calcified lesions. So, we know that coronary lesion calcification makes procedures more difficult to accomplish. It actually leads to stent underexpansion, and that leads to increased rates of early and late adverse events. And we have good tools out there to treat calcium, to fracture it, ablate it, allow our stents to deliver, and potentially expand them. And we know that those tools are essential for lesions that we need them in. And those are cases where the balloon's uncrossable or undilatable, et cetera. But what we don't know is that if we have all these technologies at our disposal, could we actually improve outcomes for unselected patients, those that you could try first with a balloon? And we don't know the answer to that. And so as a result, we actually conducted a large-scale randomized trial to test that hypothesis. And at the time we designed ECLIPSE, that was a time when we were seeing a lot of patients coming in with stent underexpansion. And the idea was, should we be doing more in these cases to get better outcomes? So we randomized 2,000 patients in the United States. They had severely calcified coronary arteries as based almost predominantly on the coronary angiogram. This used a historical definition that's largely unchanged for 30 years, and that is basically the definition. When you look at the angiogram, do you see calcification? Wires had to cross, and then patients were randomized to orbital atherectomy versus conventional balloon angioplasty, and patients were then followed for not only clinical follow-up, but we took advantage of the randomized strategy to do OCT assessment as well to see if we could improve stent areas. So the study interventions in the orbital atherectomy arm, you had to do balloon predilatation. After you did atherectomy, you did stenting, and then you post-dilated appropriately. For conventional balloons, you could use cutting and scoring balloons. Lithotripsy and OPN were not available in the United States at that time. And we strongly discouraged crossovers because we wanted to test the pure strategies themselves. I'll show you a case at the end that explains this to some extent and why we got the outcomes we did. Basically, we were looking at 2 endpoints. One was a primary imaging endpoint, looking at the OCT analysis of about 500 patients, and then looking at clinical endpoints, target vessel failure over the 1-year clinical follow-up. The baseline characteristics, as you'd expect for these types of patients, mean age of 70, diabetes in over 40% of patients, CKD in a quarter of patients, and hemodialysis in 5 to 6% of patients, and 10% prior CABG. So these are calcified lesions. I can also say they're calcified lesions because when the core lab assessed the lesions we treated, 97% of the time they felt these were severely calcified lesions using that angiographic definition, which is calcium on both sides of the vessel extending into the lesion itself. The mean reference vessel diameter was about 3, the lesion length was about 30, and then calcification length was about 40 as a whole. The procedural characteristics, we hypothesized to some extent that it might be faster to do atherectomy. It turns out that balloons are pretty fast, and in fact faster than atherectomy. And you used less ancillary equipment like microcatheters, excess wires, et cetera, by doing a balloon-based approach. Within this trial, remember the trial was designed 10 years ago, we saw the use of imaging in 62% of patients consistent across both arms. And so that is actually, I think, an admirable number based upon where we were. I think if you were doing the trial now, I would say it ought to be 100%. When we look at device usage in general in the balloon arm, cutting and scoring balloons were used in about 10% each, so a total of 20%. Otherwise, NC balloons were used with atmospheric inflations of about 18 millimeters of mercury. And in the orbital atherectomy arm, by and large, it was low speed for the most part. There was a little bit of high speed as well, and very little use of other devices like rota, laser, or lithotripsy. Procedural complications are important because we know that you could perhaps have more complications with atherectomy compared to balloon. On the other hand, if you have uncontrolled dissections, that could be a problem too. Turns out that they were largely similar in both arms, not that the only difference was a slightly increased rate of transient slow flow in the orbital atherectomy arm, but that resolved by the end of the procedure. The rates of perforation dissection were similar. When we look at the primary imaging endpoint, we saw really no significant difference between the two groups, but the honestly most striking feature of this initially, and Philippe was a co-PI, we both said this at the same time, was how big the areas were in the balloon arm. And in the balloon arm, the MSAs at the site of maximal calcium were 7. The overall MSAs in the balloon arm were basically 5.9 or so. So these are big, big areas achievable by balloons in the cohort of patients that were imaged. If you look at the overall cohort of population, you basically see no difference between the two arms, but it's not surprising if 62% of imaging was done that you see pretty much no difference between these two groups. And when we look at 1-year safety events overall, they were reassuring, no real differences, and that's reassuring, especially because at 30 days there seemed to be a little bit of excess of events in the orbital atherectomy arm. By the time out to a year, there were really no differences. In an analysis that Greg Stone presented at the ACC, the use of imaging was associated with lower rates of target vessel failure, irrespective of whether you were in the balloon arm or the orbital atherectomy arm. And so really imaging drove outcomes in some respects, didn't drive them, but were associated with lower outcomes more so than the randomized treatment. So how do I summarize the data? Well, first, it's that the routine use of orbital atherectomy did not improve MSA or reduce TVF when compared with conventional balloons. But it's not that atherectomy didn't work, it's that balloons worked far better than anticipated. Remember also that extremely calcified lesions that would be balloon uncrossable or undilatable were excluded. You couldn't be in the trial if you had lesions like that, and that's proven by the fact that only 5% of patients in the balloon arm actually crossed over. And remember, most lesions were qualified based upon the angiogram, not based upon intravascular imaging, and so that's an important point. One explanation for how well the balloon arm did is shown in a case, and I thought it was reasonable to show this. This was a patient I treated, has a calcified LAD. It could be treated both ways. In fact, when the patient was randomized to balloon, I said, oh man, it's going to struggle. It would have been much easier to just do quick atherectomy and then go from there. But what ended up happening is I dilated 3.0 NC balloon, 20 atmospheres, wired the diagonal, and you actually see that there's a nice dissection here. So you think there's good lesion preparation. You also see the dissection could potentially close down the vessel. And I would dare say that if I asked the audience, what would you do at this point? Almost everybody would put a stent in because you have a dissection, you have good prep, everything seems like it's fine. This patient was in the imaging arm of the trial, and this is what the OCT shows. Nice dissection here, and then there's an area right here of unfractured, undilated vessel right after the diagonal. I'll let it run one more time. Here's dissection, fractures, and here, no fracture, no dissection right after the diag. So it turns out that this was actually not adequately prepped, even though there's a dissection there. Now, you could say, well, if I put a stent in, it's going to be fine. Well, this is actually pretty thick calcification. And so what the OCT run showed me is I actually needed to do more. And so I took in another balloon, slightly bigger, based on the OCT size, and you can clearly see the waist. I left it up for longer, cracked, no issue, and then it's simple stenting, post-optimization, pot, and then when you look at the final image, that's what you see. Everything looks great. So balloon could work, but the reason the balloon worked was because it was facilitated by the imaging. And so what do I learn from this? It shows that for lesions like this, conventional balloons as a first approach is wholly reasonable. The initial angiogram recognized the calcium, but it was not sufficient to optimize the lesion. I really needed imaging to do that, and the use of imaging allowed me to confirm that the lesion preparation was good and facilitated safe optimization of my stents. So what's my take-home message from the trial? I think first, if you stick true to the data, it's that adequate stent expansion and low rates of adverse outcomes are achievable with conventional balloon angioplasty in a substantial proportion of severely calcified lesions. Not all lesions, but a substantial proportion of them, especially if you pay meticulous attention to lesion preparation. I also think it's really important to do randomized trials in this space instead of just sort of saying, hey, I think we ought to do this, that, and the other. And then the final point I'll make is especially with the areas that we observed in the trial, especially in the OCT cohort, This result could have happened with any technology, and I think it's therefore important to test all technologies in a randomized way. You don't have to enroll 2,000 patients. You can do it with an imaging-based endpoint, much more reasonable sample sizes, 200, 400 patients, and we'll learn a lot from doing that. So thanks so much. Happy to take any questions during the discussion period.
The third presentation for this first half is by Shao-Liang Chen, drug-coated balloon for bifurcation lesion, this DCB-BIF trial.
Well, thank you, organizer, for letting me to repeat present my DCB-BIF trial. It's a multi-center prospective randomized trial. These are my disclosure. So basically, side branch stenting is often required during provenous stenting technique, particularly for complex bifurcation lesion. Drug-coated balloon DCB for the compressed side branch have emerged as an attractive strategy. However, the benefit of DCB for coronary bifurcation lesion still remain unclear. These are the arms to investigate the treatment difference between DCB and NCB of the provenous stenting technique in patients with simple but true coronary bifurcation lesion. So from the figure you can see, we included patients with side branch lesion less than 10 millimeters with a baseline vessel diameter minimal 2.5 millimeters. Also, I think there are no more specific exclusion criteria for this trial. So the primary endpoint was a 1-year composite of target lesion failure TF, including cardiac death, target vessel myocardial infarction, or clinical-driven TAVR. Also provided several secondary endpoints. So we estimate a 1-year rate of target lesion failure in provenous stenting technique with non-compliant balloon NCB for a side branch of 17%, assumed 41% risk reduction in the provenous stenting technique with DCB for side branch. So finally, we need to include 784 patients to provide 80% power. From the flow chart, you can see for simple coronary bifurcation lesion, 2 wires, a ballooning main vessel if it's necessary, and a stenting main vessel followed by part technique. So after part, if the osteoside branch diameter stenosis is minimal 70%, so the patient will be randomized to NCB and DCB groups. In NCB groups, I think they remain stable, so they are very simple according to the provenous stenting technique. But in the DCB group, first we need to use the NCB to dilate the stent strut in the main vessel. Then we will put DCB into a side branch. After DCB angioplasty, we need to do kissing balloon inflation using 2 different NCB balloons in main vessel and inside branch. Finally, if the side branch TIMI flow less than 3, or there a type B or type C dissection, we need to deploy second stent in the side branch. So this is study flow chart. Finally, we included 784 patients in the 2 groups. So basically, you can see there was no significant difference in baseline clinical characteristics, but particularly most of patients presented unstable angina, which was seen in almost 61% of the patients. Also, there are some non-STEMI and STEMI patients, so it means a very low rate, very small proportion of patients presenting the stable angina. So most lesions are classified by Medina 111 or 011. Lesion involved in distal left main was seen in 15% in 2 groups, particularly after final kissing balloon inflation and the part. So the crossover rate from provenous stenting with 1 stent to provisional with 2 stents was less than 4% in the 2 groups. Intravascular imaging guidance was used in less than 30% of the patients. So by 1 year follow-up, the primary endpoint target lesion failure was 12.5% in the non-compliant balloon group compared to only 7.2% in the DCB group with a very significant p-value, which was mostly driven by high rates of spontaneous myocardial infarction in the non-compliant balloon. But finally, by 1 year follow-up, there was no difference in terms of the clinical treatment TAVR between groups from the table. You can see also there were 4 cases suffer from stent thrombosis in the drug-coating balloon, but no stent thrombosis at all in the non-compliant balloon. This is a Kaplan-Meier curve, shows the early separation of 2 curves starting from 2 days after randomization. So also perform subgroup analysis. Actually, there was no interaction between subgroups, but also we found profound benefits in patients older than 65 years, non-left main bifurcation lesion, also for non-IVI guided PCI group. So in conclusion, DCB-BIF is the first powered RCT to compare DCB with a non-compliant balloon during provincial stenting technique for true but simple coronary bifurcation lesion. Stenting vessel with side-branch DCB results in a lower rate of 1 year target lesion failure compared to provincial stenting technique with side-branch non-compliant balloon. But it should be very cautious to translate the clinical result from this trial because there was no significant difference in TR between 2 groups. Thanks for your attention. Thank you.
Great. So I think we have 3 trials that we are open for discussions. Anybody want to have any questions for our speakers? Maybe I'll ask Philippe first. So if you look at early TAVR, so if you look at a particular patient, can you predict whether they will have their valve or they will need the valve replaced within the next 6 months or a year? Are there clinical factors that you can actually be able to sort out the patient?
Yes, so that's we try to do this at ACC. So we try to predict acute valve syndrome. Who are the patients that are susceptible to, crash and burn and not be able to wait? And the model was a very, very, very poor discrimination, so we were not able to predict. There were some criteria that were identified. One is the inability to do a stress test. If you're not able to, you're diminished enough that you cannot walk on a stress test, you are more susceptible to convert within 6 months and also acutely, which is probably the case that they were symptomatic. Okay, so maybe we could not evaluate them. Second, there's patient with positive biomarker. Was very, very almost significant. And then after that, there's patient they were diabetic. Not sure why diabetic. They cannot feel the pain. I don't know if they're short of breath. They have more coronary disease, more comorbidity, PAD, etc. So, but again, the discrimination of the model was very poor. With a C-statistic of 0.6. So I think that if you try to gamble and guess who will be able to wait, I think you're going to be in trouble in 40% of the time.
I've got a question or a comment. I'm Bob Gerber from Australia. I'm actually one of the local PIs for the EASY trial, as you know. So my question is really your thoughts on this troublesome group of severe aortic stenosis who are asymptomatic. I often, when I'm trying to consent these patients, like, how can you be asymptomatic? Vmax is over 4, some are over 5. And then I've noticed that the patients that have email addresses or use their smartphones, they're the ones that get symptoms quicker. Mm-hmm. So is there something else that we're missing? Step counts. Mm-hmm. There was one guy who's in the EASY trial who actually is waiting for his knee to be done. That's how he presented to clinic. And so I sort of feel we're doing these studies in these asymptomatic patients, but we need to find out why they're asymptomatic, because they should be symptomatic. What are your thoughts?
Yeah, so that's fascinating. When you see, I review all the crossover, okay? So when you see 900 patient or 488 crossover, you start to understand what's going on. It's to your point. First, 20% of the patient were sent by referral doctor for a trial to be deemed asymptomatic, and when we start to talk to them, they have symptoms, stress test positive, or CT scan with class 1 indication. So first thing. Second, we have story of patient negative stress test, EF of 70%. I'm fine, training in the gym every day, and they literally 29 days after randomization, syncope, pass out, twice, VT, CPR, ambulance. So and multiple. So our capacity to judge symptom for me is after seeing all those results in series, I stopped. I think symptoms are unreliable. To your point, is there anything else? Probably, but I think it started at moderate. I think severe is way too far anyway. We try again. I call it stage 4 cancer versus stage 3.5. You're not going to see benefit of mortality. It's too late. It's already late. Biomarker, Brian Lindman showed at ACC. It's too late. When you have positive biomarker, you have worse outcome. The benefit of early TAVR was higher in patients that were negative biomarker and young. So I think we need to rethink the way to think about AS. We're a victim of Brownwell paper in 1968 using data from 1955, where the mortality actually was 75% with surgical AVR. So waiting was very compelling. Now it's different. We have 0% cardiovascular mortality in both group. So I think AI will help. AI, whatever the tool, cardiac damage. But if you have cardiac damage, it's too late. If you have Evolve, show that. If you have cardiac damage, it's too late. So more to come.
If I could ask Ajay, still here? Yeah. So, Ajay, you're a busy chip operator. We know that a lot of the severe AS patients in ECLIPSE did not have severe AS by intravascular imaging.
Severe calcium, yeah.
Oh, sorry. Did not have severe. Let me start again. You're a busy chip operator. We know that a lot of the patients in ECLIPSE, which had 97% angiographic severe AS, did not have severe AS by intravascular imaging, did not have severe calcium by intravascular imaging. Do you think we have the point where we know which patients really need calcium modification? We've got a couple of scores out there. Do you think that's enough? Do you rely on them in the cath lab, or are you still looking for something else?
Well, I think one group that definitely needs atherectomy are balloon uncrossable lesions. Those are, clearly you're going to need to do something else. But I think if the balloon crosses, then, all bets are off. And I think that some of the scoring algorithms can help. But you have to analyze the scores and act true to the way the scores were developed. And it's not something where you see a score of 2. I was at a live case a couple of weeks ago, a presentation, the score was 2, and they said we need to use lithotripsy. And that's not the way the score was designed. It was basically a score of 4 in the old one, and now it's really 3 in the new one that sort of would hinge that decision. But frankly, in light of these results, I'm not even sure that is foolproof, and you really need to test it out. I don't know, now, Deborah, you're talking, Deborah and I were talking about this beforehand, and so what are your thoughts on this as well? Does it make things more complicated now, or is it simpler because as long as you take those ones out that you don't need to treat, then the rest of them is dealer's choice?
I think it's very clear. If you go by calcium algorithm based on the sky and all that, balloon uncrossable leads to atherectomy. But then we still don't really have the realm of space where, balloon crossable or some guidelines, some protocol, they say 1-to-1 sized balloon crossable, then consider, if it doesn't cross, then consider atherectomy. So I think that's where we need more data to this. So yeah. I do have one question for you, Ajay. The ones that had a slow flow in the orbital, was it related to high-speed runs?
We haven't analyzed that yet, but what I can tell you is it was transient, and by the end of the case, the slow flow was fine. It's kind of what you'd expect in general. I think one thing that's interesting is that you tend to see less slow flow and microvascular dysfunction with orbital than compared to rota. We actually studied that in a randomized trial looking at microvascular dysfunction, but by the end of the case, they were basically the same. But yeah, I think the other thing too is I didn't really focus on the 30-day events, but there were definitely some adverse events with orbital up front that if you look at the cases, and Philippe and I looked at all these cases, there were some pretty obvious ones where really it shouldn't have been done. for instance, wire down the vessel, there's no flow in the vessel, it's a small vessel and it's an angulated circ. Like at that point, you stop. You don't do atherectomy. And yet, atherectomy was done, and predictably there was a complication. Other cases where EF is down, LAD is occluded, bifurcation of a circ, both limbs were atherectomized, and then the right was done as well with atherectomy, no right heart cath, no hemodynamic support. 6 hours later, the patient goes into shock. So I think for atherectomy as a tool, interventionalists need to know how to do it, and they need to know when to do it, how to do it, when to be more careful, when not to. I think, well, generally you always want to be careful, but I think those are important points.
Okay, great. So we're going to have to move on to the second part of the session. The first presentation by Dr. Wang from Hangzhou, China, key findings of the FLAVOUR 2 trial. Dr. Wang.
Okay, dear moderator and panelists, a lot of friends in the floor. So thank you for giving me the opportunity to share my presentation about FLAVOUR 2 trial. So here's my disclosure. So what is about the background for the FLAVOUR 2 trial? So in our daily practice, we know a comprehensive strategy is essential for patients with coronary artery disease, so which includes decision-making for angioplasty and optimizing the PCI procedures. So physiology assessment is effective in guiding PCI decision-making. However, despite strong recommendations and robust evidences, the global application of conventional wire-based physiology assessment in clinical practice remains limited. Angioplasty is a simplified physiology assessment obtained directly from angiography without additional invasive procedure and already have achieved a Class 1B recommendation in current guidelines. So in addition to the role of decision-making, angioplasty could be used for optimizing procedure. Intravascular imaging plays a key role in optimizing PCI procedure and is superior to angiography-only guided PCI. So what is the difference in outcomes when a single modality is used for both purposes remain unclear. So the objective and the hypothesis when employed as a comprehensive strategy encompassing both PCI decision-making and procedure optimization, whether a novel computational physiologic technique can perform as effective as the most commonly used conventional intravascular imaging technique. So the aim of the study is to compare the efficacy of angioplasty and iris-guided PCI strategies in patients with angiographically significant stenosis. The hypothesis is that the angioplasty-guided PCI strategy will be non-inferior to the iris-guided PCI strategy in terms of clinical outcomes at 1 year. Here are clinical outcomes and a sample size. So the primary outcomes is a composite of death, myocardial infarction, or revascularization at 12 months. So here's the study organization. So FLAVOUR 2 study is an investigator-initiated, multi-center, non-inferiority randomized trial. So the enrollment of patients were performed at 22 centers in China. So regarding the study design and the patient population, so here we list the key inclusion and exclusion criteria. So the patients with angiographic stenosis of 50% or greater were enrolled. So here's about the indications and optimization criteria for angioplasty. So in the angioplasty-guided PCI group, so angioplasty 0.8 or less than 0.8 were indicator for the angioplasty. So the post-PCI angioplasty 0.88 or larger, or that angioplasty less than 0.05, so it's see as the optimal PCI goal. So in the iris-guided PCI group, MRA 3 millimeter square or less, or MRA between 3 to 4 plus plaque burden large 70%, is an indication for the angioplasty. So the optimal goal for PCI in this group is a plaque burden at a standard age, 55% or less, minimum standard area larger than 5.5 millimeters square or larger, or plaque burden at a standard age, 55% or less than 55%, minimum standard area equals to or larger than distal reference lumen area. So more than 4,000 patients were screened from 22 sites. So 1,870 patients were enrolled. Finally, 1,839 patients were successfully randomized to either NGFR group or IVUS group. The follow-up rate is very high in both groups. More than almost 99% of patients finished the 1-year follow-up. So here's a basic clinical characteristics. So there was no significant difference between two groups. So in terms of age, sex, diagnosis, diabetes rate, hypertension rate, current smoking rate, and prior myocardial infarction rate. So what is about the procedure characteristics? So we can see the NGFR group has a lower PCI rate of patients, and also have less the total stent number per patient, and also has the NGFR group has a higher achieved a higher PCI optimization rate. So obviously, of course, depending on the different definition. So also we can see the total target vessel number is significantly lower in NGFR group compared to that in IVUS group. So in terms of primary outcome, so there was no significant difference between two groups. So the p-value for non-inferiority is 0.02. So non-inferiority was well established. In terms of key secondary outcomes, including death, myocardial infarction, revascularization, and a stroke. So between the two groups, so we can see here. So there's no, in terms of the individual component of the primary endpoints, so there's no significant difference between the two groups. So also here we can see that the pre-specified subgroup analysis, we also didn't see the significant difference between the two groups. So in terms of the primary outcomes, according to different treatment, medical treatment, and the PCI treatment, so in either one, we didn't see the difference between the two groups. In either medical treatment group and the PCI, with the medical treatment and with the PCI treatment, we didn't see significant difference between the two groups. So here's the limitations of FLAVOUR 2 study. So the study population has a relatively low anatomic complexity with a median syntax score around 9. So the PCI criteria in the IVUS group may have contributed to the higher PCI rate. So given the lack of definitive standard for IVUS-guided revascularization. So the higher PCI optimization rate was influenced by both the NGFR technique itself and the criteria used to define optimization. So as no universally accepted standard for NGFR-based PCI optimization exists. So conclusion for the FLAVOUR 2 study of my presentation. So in the patients with a non-complex coronary artery disease, the NGFR-guided comprehensive PCI strategy encompassing PCI decision-making and standard optimization was non-inferior to the IVUS-guided strategy with respect to the composite of endpoint of death, myocardial infarction, or revascularization at 1 year. So this finding might have implications for future guidelines on its role and application. So thank you all.
Thank you, Dr. Wang. We'll come back to for discussion later. So next speaker is my colleague, Dr. Bill Weon from Stanford. He's going to talk about long-term final 5-year results of the FAME-3 trial.
Thanks, Alan. So previous studies in patients with 3-vessel coronary artery disease have shown that coronary artery bypass grafting results in lower rates of the composite of death, stroke, or myocardial infarction compared with percutaneous coronary intervention at long-term follow-up. These results, however, are outdated given improvements in percutaneous and surgical techniques and in medical therapy. The FAME-3 trial compares FFR-guided PCI using current generation DES with contemporary CABG, both in conjunction with guideline-directed medical therapy. At 1 year, PCI failed to meet the primary endpoint of non-inferiority compared with CABG with respect to the composite of death, stroke, MI, or repeat revascularization. However, a pre-specified key secondary endpoint focusing on death, stroke, or MI at 3 years was not different between the two groups, although there was a trend favoring CABG. In older studies, the improved outcomes after CABG continue to increase with longer-term follow-up. In this study, we report the pre-specified final 5-year follow-up of the FAME-3 trial for the clinically important outcome of death, stroke, or MI. FAME-3 is sponsored by Stanford University and funded from research grants from Medtronic and Abbott. You see the the other organization of the study on this slide. As a reminder, it involves all comers with 3-vessel disease, not involving the left main. Patients were randomized to FFR-guided PCI or to CABG, and the primary endpoint, again, is 5-year incidence of death, stroke, or MI. To be included, you had to have at least 50% diameter stenosis in all 3 major epicardial vessels and be amenable to both PCI and CABG. Exclusion criteria were cardiogenic shock, a recent STEMI, or a very low ejection fraction. 1,500 patients were enrolled, 757 randomized to PCI, 743 to CABG. We achieved 95% follow-up at 5 years in the total population. The baseline characteristics were typical for a study like this, mostly middle-aged men with typical risk factors. About 30% had diabetes, 40% presented with ACS. About a little over 4 lesions were identified in both groups. Roughly a fifth of patients had a chronic total occlusion and 2/3 had a bifurcation lesion. So these were fairly complex patients. The syntax score was 26 in both groups. FFR was able to be measured in 82% of lesions, and about a quarter of them had negative FFRs. 3.7 stents were placed on average per patient. 3.4 distal anastomoses were placed in the surgical arm. 25% of patients had multiple arterial grafts, and 24% underwent off-pump surgery. Medical therapy at 5 years was excellent in both groups. Roughly 90% of patients were on at least one antiplatelet agent. Statins were given to over 91% of patients, beta blockers over 70%, ACE inhibitors or ARBs over to 70%, and there were no major differences between the two groups. So the primary endpoint, death, stroke, or MI at 5 years, was not different between the two groups, occurring in 16% of the PCI patients and 14.1% of the CABG patients, for a hazard ratio of 1.16 and a p-value of 0.27. Interestingly, on a landmark analysis looking at the event rate after 1 year, there was no difference. So we did not see any late accrual of benefit with CABG like other studies had shown. When we look at the secondary endpoints, death occurred in 7.2% of patients in both arms. Stroke was 1.1% less common after PCI, while MI was 2.9% more common after PCI. Repeat revascularization remained higher, as did the composite of death, stroke, MI, or repeat revascularization. If we used a different definition for procedural MI, the SKY definition, which has been validated in other studies, you see that the death, stroke, or MI rate occurred in 20% of PCI versus 23.7% of CABG patients. When we looked at subgroup analyses, there was only one interaction, and that was based on the syntax score. You see that patients with a low syntax score fared better with PCI, whereas patients with an intermediate score fared better with CABG. It's also important to compare FAME3 to historical control studies like the syntax trial. When we look at baseline characteristics, the two groups had remarkably similar characteristics with similar age, similar percentage of sex and risk factors, and similar number of lesions treated, as well as syntax score. Yet despite that, the outcomes were quite different. When you look at death, stroke, or MI at 5 years in syntax, it occurred in 22% of the PCI group versus 14% in the CABG, highly statistically different. Whereas, as I mentioned in FAME3, there was no difference. And if we just focus on death alone, there was an over 5% difference, absolute difference in death in syntax, whereas, as I mentioned in FAME3, there was no difference at all. So in conclusion, in patients with 3-vessel coronary disease, there's no significant difference in the composite of death, stroke, or MI after FFR-guided PCI with a current generation DES in comparison with CABG after 5 years. The incidence of death in the two groups was the same. The incidence of MI was higher after PCI, 2.9% absolute difference. In a landmark analysis, after 1 year, there was no late accrual of benefit with CABG. And these results differ strikingly from the 3-vessel disease cohort in the syntax trial, where the composite of death, stroke, or MI was significantly higher after PCI, as was the incidence of death alone. The difference in outcomes at 5 years between PCI and CABG has narrowed, likely due to improved stent technology, the routine application of FFR-guided PCI, and greater adherence to guideline-directed medical therapy. Patients with lower coronary anatomic complexity, based on the syntax score, do better with PCI, while patients with greater complexity do better with CABG. The FAME3 trial provides contemporary data regarding outcomes after PCI using current generation DS compared with CABG in patients with 3-vessel coronary disease, which can facilitate improved shared decision-making between physicians and patients. If you'd like more information on the study, there's a link on the bottom of this slide that you can click on, and that'll get you access to the PDF. Thank you for your attention.
Our next presentation by Hae-Soo Kim from Korea, Stratified Randomization Study to compare different duration of DAPT after coronary stenting in either high or low bleeding risk population.
I'm glad to present host BR-RCT, the first report. My disclosure. Bleeding emerges as a very important prognostic factor after PCI, like thrombosis. Thus, I participate in academic research consortium to define HBR. Definition is patients having annual major bleeding 4% or more within a year after PCI. We propose 10 major criteria and 2 minor criteria such as age and NSAID usage. But no previous study has evaluated specific duration of DAPT stratified according to ARC-defined bleeding risk. And general recommendation is 1 to 3 month DAPT for high BL or 3 to 12 month DAPT for low BL. However, we do not have evidence based on ARC HBRI criteria which duration would be optimal. Host BL is the first randomized study to stratify patients receiving PCI with DES according to BL based on ARC definition, and to test different duration of DAPT either in high or low BL population. We stratified the patients into high or low BL stratum and randomized them into 1 versus 3 month DAPT or 3 first 12-month depth. We set 3 co-primary endpoints that were assessed in hierarchical order. The first component is NACE. Second, MACE. Third, any actionable bleeding, BARC type 2, 3, 5 bleeding. Hypothesis is within each stratum, the short depth be non-inferior to longer depth for the first and second component and be superior for the third component of co-primary endpoints. 1,600 patients were required in high BR stratum. We assumed NACE at 1 year as 7 or 9%. We set margin as 2.7% difference, corresponding to hazard ratio 1.3. 3,300 patients are required in low BR stratum. We assumed NACE at 1 year as 4 or 5%. We set non-inferiority margin, absolute risk difference 1.5%. Here is a study flow. About 5,000 patients were enrolled and stratified into high or non-high BR stratum. And this stratum randomized into 1 versus 3-month depth. This stratum, 3 versus 12-month depth. And we checked 1-year primary endpoints. There's actual flow of the patients, first stratified into high or non-high bleeding risk stratum, and randomized into 1 versus 3, 3 versus 12-month depth, and we completed a 1-year follow-up in over 99% of the patients. Baseline profiles of high BR stratum shown here, age 73, female 1/3, stable 40%, ACS 60%, among them STEMI 5%, DM over half, CKD 1/3, previous PCI 20%. CKD is prevalent. This creatinine level is about baseline is about 2. Clopidogrel is mainly used as a DAPT in 90% of the patients. Anticoagulant user is about 17%. Here's profiles of low BR stratum, age younger, 63 years, female less, about 20%, stable 40, ACS 60, among them STEMI 10%, DM 1/3, CKD rare. Of course, clopidogrel is mainly used as a DIPT in about 75% of the patients. This is actual real-world practice in Korea. Here's primary endpoints. The first component, 1-year NACE in high BR stratum, happened in 18.4% after 1-month depth, 14% after 3-month depth. Difference is about 4.4%. Confidence interval crossed margin, 2.7%. 1-month depth did not meet non-inferiority to 3-month, higher. Thus, we did not continue statistical analysis for the second or third component. Here are just the results. Second component, 1-year MACE in this stratum, 9.8% after 1-month depth, 5.8% after 3-month depth. Difference is about 4%. Significantly higher. The third component is any actionable bleeding in high BR stratum happened in about 13.8% after 1-month depth and 15.8% after 3-month depth. Here is primary endpoints in low BR stratum. The first component, 1-year NACE, happened 2.9% after 3 months, 4.4% after 12-month depth. Absolute difference is minus 1.5%. It is within the margin, plus 1.5%. 3-month meet non-inferiority to 12-month depth. Actually, it was superior. Second component is MACE in low BR stratum, 2.2, 2.3. Non-inferiority was met. The third component, any actionable bleeding in low BR stratum, happened 7.8% 4% after 3 months, 11.7% after 12 months. 3 months was superior to 12-month TAPT. Here's each component of clinical outcomes of high BR stratum treated with either 1 month versus 3 month TAPT. 1 month showed higher instance of NACE, MACE, CV death, ischemic stroke, target lesion revascularization, low instance of minor bleeding, no difference in major bleeding. Here's each component of low BR stratum treated with either 3 versus 12-month TAPT. 3-month TAPT showed low instance of any bleeding, hemorrhage stroke, minor major bleeding, without increasing thrombotic event. Limitations of labor study, usage of specific P2Y12 inhibitor was left to the doctor's discretion. Thus, clopidogrel was mainly used as a PY inhibitor at discharge because most physicians in this region well acknowledge that key RCTs of ACS or AMI enrolling East Asians have shown that clopidogrel is superior to ticagrelor, leading to clopidogrel as the standard and most frequently used regimen, although TICADAPT is recommended for ACS in Western world. The findings may not be generalizable to all ethnic groups, but optimal duration of clopidogrel for East Asian may be applicable to TICADAPT for Westerners. Conclusion, for HBR patients, 1 month DAPT did not meet non-inferiority to 3 month DAPT for NACE. Actually, 1 month DAPT was inferior to 3 month DAPT for NACE and MACE at 1 year, while there was no significant difference in any actionable bleeding. For low BR population, 3 month DAPT reduced any actionable bleeding without increasing NACE or MACE as compared with 12-month DAPT. Overall, 3 months would be the optimal default duration of DAPT after PCI in general to meet the balance of thrombosis and bleeding. Thank you very much for your attention.
That's yours.
So the last trial to be presented is by Dr. Junyoung Han from Samsung Medical Center. He's going to talk about clopidogrel versus aspirin monotherapy in high-risk patients after PCI Smart Choice 3 trial.
Thank you, Chairman. Good afternoon, everyone. These are my disclosures. Standard practice has been to recommend indefinite aspirin monotherapy following DAPT for the prevention of subsequent severe events among patients undergoing PCI. However, data supporting the use of aspirin as a single antiplatelet therapy after DAPT have been debated. Clopidogrel has been suggested as a potentially superior alternative to aspirin, although the evidence is limited, with only one trial, the host exam, directly comparing them after PCI. Therefore, a large-scale trial comparing clopidogrel and aspirin with a strict hard endpoint is necessary to establish definitive evidence. Moreover, targeting higher-risk patients may help identify those who would benefit most from clopidogrel monotherapy. The objective of this study was to ascertain the efficacy and safety of clopidogrel monotherapy compared with aspirin monotherapy beyond the standard duration of DAPT after PCI in patients at high risk of recurrent ischemic events. Our hypothesis was that clopidogrel monotherapy would be superior to aspirin monotherapy. The Smart Choice 3 was an investigator-initiated, randomized, open-label, multi-center trial at 26 sites in South Korea. Patients at high risk of recurrent ischemic events who completed a standard duration of DAPT after PCI were randomly assigned in a one-to-one fashion to receive either clopidogrel monotherapy, 75 milligram once a day, or aspirin monotherapy, 100 milligram once a day. The randomization was stratified by clinical presentation at the index PCI and a participating center. Patients were eligible if they had undergone successful PCI with DS, had received a standard duration of DAPT, 12 months or longer for MI, and 6 months or longer for stable ischemic heart disease, and had no severe events after the index PCI. Patients also had to have at least one clinical characteristics, previous MI or medication-treated DM, or complex coronary artery lesion characteristic following renovate complex PCI. Key exclusion criteria included ongoing long-term treatment with oral anticoagulants, need of DAPT for any reason other than coronary artery disease, use of a single antiplatelet therapy as screening, etc. The primary endpoint of this study was the major adverse cardiac and cerebrovascular events, MACCE, defined as a composite of death from any cause, MI, or stroke. Secondary endpoints included the individual component of the primary endpoint, bleeding, BAR type 2, 3, or 5, upper gastrointestinal clinical event, and net adverse clinical events defined as MACC plus major bleeding, BAR type 3 or 5. We expected that annual event rate of the primary endpoint would be 4.0% in the aspirin group and 3.0% in the clopidogrel group, corresponding 25% relative risk reduction. With a accrual period of 3 years and an additional follow-up of 1 year after the last patient enrollment, a total of 5,000 patients would provide a power of 82%. When the original target sample size of 5,000 patients was reached ahead of the planned accrual period, we decided to continue enrolling patients until the end of the planned recruitment period. From August 2020 to July 2023, a total of 5,506 patients underwent randomization, with 2,752 assigned to clopidogrel group and 2,722 assigned to the aspirin group. Almost 99% of all patients completed at least 1 year follow-up. The primary analysis was done by intention to treat principle. The proportion of patients who was deviated from the protocol was not significantly different between the two groups, 4.6% in the clopidogrel group and 5.8% in the aspirin group. Baseline patient characteristics were well balanced between the two groups. Median age was 65. The proportion of women was less than 20%. There was no significant difference in enrollment criteria and comorbidities between the two groups. The proportion of patients with high bleeding risk by ARC was about 15% in both groups, and the time from PCI to randomization was 17.5 months. Medication at randomization were well balanced between the two groups. During median follow-up of 2.3 years, the cumulative incidence of the primary endpoint was 6.6% in the aspirin group and 4.4% in the clopidogrel group. The difference was statistically significant, and the hazard ratio was 0.71, and NNT was 45. The benefit of clopidogrel was mainly due to reduction in MI, 2.2% versus 1.0%. However, there was no significant difference in bleeding. In secondary endpoints analysis, the incidence of death from severe cause or MI were lower in the clopidogrel group compared with the aspirin group. There was no significant difference in major bleeding between the two groups. Upper gastrointestinal clinical event and net adverse clinical event occurred less frequently in the clopidogrel group compared with the aspirin group. The sensitivity analysis for per protocol population showed a consistent benefit of clopidogrel. In pre-specified subgroup analysis, the benefit of clopidogrel was consistent across various subgroups. However, there was significant interaction between the treatment effect of clopidogrel and clinical presentation at the index PCI. This study had several limitations. The trial had an open-label design. The actual event rate was lower than expected, and this study exclusively enrolled Korean patients. In conclusion, among patients who were at high risk of recurrent ischemic events and completed the standard duration DAPT following PCI, clopidogrel monotherapy resulted in a lower risk of MACCE compared with the aspirin monotherapy without increase in bleeding. The SMART Choice 3 trial was the first to demonstrate the benefits of clopidogrel monotherapy compared with the aspirin monotherapy and a composite of hard endpoints in patients at a high risk of recurrent ischemic events after PCI. Thank you for your attention.
We have about 5 minutes for questions and any particular questions?
Yeah, I do have a question for Dr. Han. These are high-risk patients. So when you switch from, like, if the DAPT regimen before randomization to now clopidogrel monotherapy, especially East Asian population, there's clopidogrel resistance. Is there any selective protocols where you do, like, platelet reactivity testing or genomic testing for certain populations?
Yeah, thank you for an excellent question. We did not include any platelet function test or a genotype test at the enrollment. However, in the exploratory analysis, we did genotyping. In those studies, there was no significant difference between the rapid and normal metabolizer and intermediate and poor metabolizer with regard to MACCE in the clopidogrel monotherapy group.
A question for Bill. So when you look at, obviously PCI always lose out to bypass because of the repeat revascularization. So at the follow-up at 5 years, a lot of the repeat revascularization of the original lesions or progression. So that's one piece, but then how is the medical therapy followed? That remind me, meaning are we pretty strict in looking at how the LDL is? I don't remember that we actually had that in the protocol.
Yeah, so unfortunately regarding the medical therapy, we didn't, we had limited funds for the study. This was investigator initiated and run, and so we did, tabulate what meds patients were prescribed and presumably taking at each year up to 5 years. So we had those data, but we didn't have, and we had baseline laboratory studies, but we didn't have laboratory studies at all the follow-up standpoint, so we don't know that for sure. And the repeat revascularization, I mean, I think that's, I think people are moving away from that endpoint. Like I mentioned, we wanted to sort of mimic syntax at 1 year, so that's why we included it. But of course, it's a kind of a biased endpoint. It's a physician's decision. It's not even really an endpoint. It's not an event. It's a decision. And studies have shown that people are more likely to take PCI patients back over CABG patients because they're more straightforward. It isn't clear that the repeat revasc even leads to increased mortality. It didn't certainly in FAME3. So I think a lot of people view that as, shouldn't be included. And things like rehospitalization might be just as relevant, especially to patients, since repeat revasc can often be done as an outpatient, and it's not as big a deal.
Thank you.
Okay, great. So I think we'll call it a day or close to an evening. I want to thank the speakers, panelists, co-moderator, and the audience, and enjoy your evening.